Thank you very much for coming to this RANDA event. Before we begin the proceedings, I would like to acknowledge and pay respect to the traditional owners of the land on which we meet, the Gadigal people of the Eora Nation. It is upon their ancestral lands that the University of Notre Dame is built. As we share our own knowledge, teaching, learning, and research practices within this university, may we also pay respect to the knowledge embedded forever within the Aboriginal custodianship of country. So it's my great pleasure to welcome you to this RANDA guest speaker event. RANDA is the Research Association of Mandus, chaired by Haysam Faraj and myself. I'd like to acknowledge Sam's efforts in getting this event together and also the sponsorship and assistance that has come from Mandus, our president, Louis Charalam, is in the back there. Yeah. We also have honoured guests, Professor Stevie Chan and my beautiful wife, Michelle Attard. So we'll try and integrate the theme of, today is a special day, it's a special night. Being the 14th of February is not only for lovers, but for all of you here who will probably forsake many a Valentine's Day working as a doctor and helping those in need. So Professor Malhi is actually my boss, so it is actually a bit awkward to see him on Valentine's Day night. But here we are anyway. So RANDA takes pride in inviting incredible doctors who are also world-leading researchers to speak to the student cohort about their clinical practice, research and career. And they're those who are driven to make changes within their own field. And of such incredible doctors, our speaker tonight, Professor Gin Malhi, will be a standout. Let me introduce Professor Malhi to you. Professor Malhi is Executive and Clinical Director of the CADE Clinic, a specialist mood disorders clinic and research facility out at North Shore Hospital, where he is also a senior consultant. He is a Professor of Psychiatry at the University of Sydney and has published over 600 research items, including books and book chapters. Last year, he was named in the top 1% of researchers in the field category of neurosciences and behaviour, globally by citations alone. Professor Malhi is the editor of 2 journals and has been awarded both nationally and internationally competitive grants for his work, which has changed the way doctors treat bipolar disorder and depression and prevent suicide in practice across the globe. Just letting you know that the talk will be recorded and Professor will take your questions at the end. Without further ado, I'd like to thank Professor Malhi in making time to speak to the student cohort at Notre Dame at the School of Medicine, and invite you now to welcome Professor Gin Malhi.
Forward. Yeah. Well, while Tim's setting up, happy Valentine's for everyone. I must say I was a bit worried when Tim introduced Professor Chan and his wife in the same sentence. I did get flashbacks to my own student years thinking, am I in the right time zone here? Thank you very much for having me here. I must say, Tim, you certainly know how to put on a Valentine's Day. I hadn't imagined I'd be here, particularly since I spent an hour and 5 minutes in a cab coming for about, 7 kilometres from Royal North Shore Hospital at a snail's pace. So I am truly pleased to be here, to get here. I genuinely thought I'd be here about 45 minutes ago, having nosh with yourselves and enjoying. But yes, as the time ticked away, I think I ranked him twice, texted him twice, saying, now we're here. Anyway, thank you for this. And look, this is a unique opportunity because I know you guys have had a busy day. You've had lectures and you're learning and you're studying, and the brain can only take so much in terms of imbibing information and understanding the world around us. And I've been in this game for a long time and remember vividly attending lectures from 9 o'clock till 5 or 6, and then having activities in the evening and so on. And your course particularly is very intense. So this is not going to be another lecture. This is not another didactic thing for you to take away. As Tim said, I've published a lot of papers. If you're interested in any of the areas, most of those are online. They're available. You're bright people. You can imbibe in your own time and absorb what you need to know. This evening is a little bit about discussion around medicine itself, why you want to be a doctor, why you want to be a psychiatrist, what it is I do, what actually turns me on in terms of continuing to do research, and hopefully that'll resonate with some of the things that you want to do in terms of your wonderful careers ahead of you. So it's called Bipolar and Beyond, more so because Tim will tell you, and if you ever look at my papers, you'll see I love alliteration, I love using poems and quotes, etc. And so this is more gimmicky than it is in terms of substance, but I'll touch on depression. I will touch a little bit on depression, but bipolar itself is a branch of depression per se, and so we can discuss that in and of itself. The beyond and the ups and downs of psychiatry pertains more so to the trials and tribulations of a career in medicine, particularly as of today. In some ways, people before you have had it a lot easier in the sense that the status of doctors was perhaps slightly different in years gone by. There was less competition in terms of getting into schools, even though there are more medical schools now. So you guys are having to struggle a lot more, first of all, to get on the bottom rung, and then it's a pretty long climb. Having said that, at the other end, things are actually somewhat rosier as well in certain areas, in that the working hours are a little bit more agreeable and the actual remuneration's good. But having said all of that, again, it depends what you end up doing. And the most important thing for you is to have your passions fulfilled. If you really want to be a good doctor, you've got to be doing something you really enjoy, something you jump out of bed for and want to do every day, so that it doesn't actually feel like work. And I'm in a very privileged position where I feel that a very small percentage of my time feels like work, in the sense that this is something I have to do because it's something that's required, and I'm not enjoying it wholly. But most of my stuff is tremendous, and that includes, in particular, contact with people. Now, given it is the 14th, I thought we ought to turn to the bard and start with something he said, just to get the mood and the ambiance for the evening. But also, because there is a serious point here, and you probably tell from my accent, I'm from the UK, I really think one of the things you need to do throughout your career is cultivate this idea of thinking clearly and being specific about what you say. And a lot of that in medicine is around naming things, identifying things, being particular, not in an obsessive way, but actually developing a language that you can communicate both with your patients at one level, but then with each other at another level. And that's part of being a doctor. But one of the masters of this, and you can keep on studying this gentleman's work for the rest of your life, is William Shakespeare. And just reading this is just wonderful. When in disgrace with fortune and men's eyes, I all alone beweep my outcast state, and trouble deaf heaven with my bootless cries, and look upon myself and curse my fate, wishing me like to one more rich in hope, featured like him with friends possessed, desiring this man's art and that man's scope, with what I most enjoy contented least. Yet in these thoughts myself almost despising, haply I think on thee, and then my state, like to the lark at break of day rising from sullen earth, sings hymns at heaven's gate. For thy sweet love, remembered such wealth brings, that then I scorn to change my state with kings. I mean, you're left speechless. If you're not moved by that, you're not human. And I'm really reading that also because what does it actually mean to be human? Why does that resonate? And what I've just done there, at one level, we take it for granted. But I've read you some words which have probably conjured up images, emotions, ideas. And one of the things around psychiatry and what interests me in the brain is what is that process? Because if you start to break it down, it's quite phenomenal. How does that actually occur? And how does when we see it in a vat, the brain actually achieve this? It's just a sort of gelatinous tissue. And yet we're able to create an image, an impression of the world, interact with that world, and communicate to other people who are also supposedly seeing what we see and experiencing what we see. And I say supposedly because we don't really know if that's real. And that's a philosophical question. And another aspect that impacts upon or impinges on psychiatry. So I'll come back to my interest per se, but I just thought we'd start with that because it is in tune with some of the things that are happening today outside of this lecture theatre. It's all about emotion. Talking about emotion and going back to my own childhood, one of the key questions that I sort of struggled with, and I'm sure all of us have gone through that process in a process of individuation, is looking up at the stars and wondering why we're here. What is it that makes us or us in terms of being unique humans and being able to introspect? It's also a time when you develop this capacity for theory of mind. So you've probably heard about mentalizing theory of mind, the idea of being able to put yourself in the shoes of others. But where does that process begin? Is it experiential, or is it a purely cognitive process? Is it something that we learn to do by purely having some skill set which allows us to mirror the thoughts of others? Another aspect you've probably heard about in science at the moment is mirror neurons, for example. This idea that behaviours are imitated. Now, it hasn't been proven as yet how that works, but what's really interesting is that some of the knowledge from one generation could well be encoded in the brain and passed on to another generation. Now just think about that for a second. That means that not just your makeup or your constitution in terms of what parts of the brain you have or what parts of the body you have, but actually what experiences the brain has experienced throughout its course could be encoded in the genetic makeup and passed on. Now, if that's the case, then actually our experiences are cumulative over generations. And this is where psychotherapy comes in to some extent. People think about ideas about your parents, your grandparents, and there being some sort of lived self being passed on from one generation to the next. When I was younger, I used to ponder a lot about oneself, identity, and so on. And I was more interested in space and mathematics and other aspects of science than medicine per se. And one thing that I really was struggling with was this concept of time. And it's wonderful to know that actually no one understands it. No one has a real understanding of what time is. And more recently, listening to a number of academics talking about this, a new theory has emerged that perhaps it is core and fundamental to our existence. So unlike other parameters, such as space, which we experience and we learn about, time is somehow intrinsically bound with our very sense of being. Now that's interesting to me currently because I mentioned bipolar disorder, and one of the things that's happening in this field is the idea that perhaps this is a disorder that is coded purely by genes. That's to say there are clock genes in the brain that determine the rhythm of various aspects of human function, including mentation, and perhaps there's some aberration in that leads to changes in mood. That would also explain why, again, it has a very strong genetic basis. I'm jumping around from topic to topic, but trying to link the ideas across science to medicine and to the models that we utilize, hopefully enticing you to think of your basic science degrees and perhaps bringing that into medicine itself. Because my understanding is all of you are postgrads in the sense you've all done a degree from some other field. And that's fantastic because you'll be rather unique. There's a lot of people who go into medicine as undergrads and they don't really have much else other than medicine. But you have the capacity to build on at least one other subject. And sometimes some of you who've done PhDs or higher degrees in that subject will have a lot of expertise to bring into medicine. And medicine actually needs that right now because it impinges on so many aspects of science in general. It can't afford to be a narrow and specialized discipline without drawing on all these other aspects. So my interest in maths, my interest in physics, all came together very nicely in medicine because medicine does provide you a flavor of each. Now, I will just, in terms of a show of hands, would like to get a sense of how many of you see yourselves being specialists as opposed to general practitioners, like you want to be a specialist of some sort. Okay, and I'm assuming that those that haven't put their hands up are undecided, or is there anyone who's undecided, or I'm going to say the rest are just general practitioners? Who's undecided? Okay, look, I think that's healthy. I think actually that's heartening, actually, that a lot of you are not sure yet because you haven't seen enough of medicine. And specializing clearly has some of its some advantages in terms of your particular career, progression, but I would say to you that it's probably good, those people who are undecided, to remain undecided for as long as possible. The reason being, unless you've got direct experience of your particular specialty, you really don't get a sense of what it's going to be like. Another digression would be that in terms of your careers, do think about what your day is going to be like. So, for example, my day began with a Skype call overseas, which was related to work, saw patients from 8 till 11:30, then went to a registrar teaching session. I then saw my research team. We then had some other meetings. I then took a few telephone calls, and then did some administrative work, and then I've run over here. Now, that may sound, well, what's so exciting about that? Well, seeing the patients in the morning was particularly exciting. The research meetings were very stimulating. And then the Skype call this morning around a research program was again, interesting. Not exciting, but interesting. But as a whole, the day's very varied. I'm not just doing one thing at a time. And that's not because I have a low threshold for excitement and get bored easily, which is true. And all of you do as well, because you're bright people. But it also means I'm able to take things from one area to the other. And the fact that I remain interested and engaged means that when I'm with patients, I am switched on. I am interested in them. If I was doing just that all the time, 6 days a week, that would be pretty hard, both on the patients and myself. So just bear that in mind. In terms of your interest and enthusiasm, that's what really drives medicine. And so you need to bring whatever you've already done into your field. So you want to be a doctor. That's quite clear. All of you here have committed to that. And here I've just got a couple of examples of some of my favorite doctors. I mean, this was, obviously a fantasy doctor in Star Trek, and then you've got Doctor Who and so on. But, they always used to have a special place. And I think, remember that as a doctor, you do have a special place in society. And it's important that you cultivate that. That also obviously brings other responsibilities. There's others who are somewhat more frivolous, perhaps, probably more pertinent to today's theme. And then there's my own profession. Recently been watching a series called Lewis, which is an offshoot of Morse. I'm sure some of you know about it. It's a detective story based in Oxford. And the detectives, time and time again, in every series, what seems to happen is that all the professors in Oxford have some sort of homicidal tendency and have killed someone, and so they investigate the murder and they find out which particular professor did it. And one of the detectives eventually sort of walks out of one of the offices having seen and interviewed this mathematics professor who goes on about various crystals that she makes her own necklaces from and so on. And as he turns to his partner, he turns around and says, yet another Oxford academic nutcase. And I think this is the thing that you have to be careful of, not to be pigeonholed into in terms of why academia or why people go into academia. It is usually because of genuine enthusiasm for patient care, but in order to achieve that, you do have to sometimes undertake slightly esoteric pathways. So let me go back to that question, what makes us tick and what makes us? This is really core, and this is the sort of thing that you can actually contemplate anywhere, anytime, and in fact all the time. You don't have to be sitting at a desk to do that. And that's what I really enjoy about it, because it's something that I can be driving and thinking about. And now we are blessed with having tools that allow us to do this. And I'm going to pause here a second to just thank Tim A for making this possible. But as Tim said, very generously, I'm his boss, only very part-time now. But, he did tremendously, having worked with me for many, many years. And he did his PhD over at University of Sydney as well. And we had access to brain imaging. And so I'm going to be showing a little bit of that. What is important is that we actually now can see the brain in terms of its function. We not just be able to see its structure, but how it's thinking. I still don't think we're anywhere near where we need to be in terms of understanding ideas. And there's a huge leap from what we see in terms of activity within the brain and what it's actually doing in terms of processing. But that leap of faith is something that we can make. And I think the various technologies that we have certainly are giving us wonderful insights into what is probably the most fantastic frontier ahead of you. Now, if this starts sounding a little bit like a car sales pitch, all right, it is. All right, okay? I'm unashamedly saying to you, now that you're wanting to become a doctor, be a super doctor. Be a brain doctor. Be a psychiatrist. Now, what I want to do, Tim, is have that played on loop. Okay, and then they take it away in their phones, and when they go to sleep, be a psychiatrist, be a psychiatrist, you're a psychiatrist. Okay? That is your mantra. Anything less, and what is the point? Okay? So this is the... I'm a psychiatrist, anything less, what is the point? That's what you should be singing in the shower, talking to your friends. Okay? Psychiatry, brain science, that's what you really want to be able to engage in. No, but genuinely, it is absolutely fascinating. And the other day I was hearing what they can do now in cardiology. There's their sort of avatar, some sort of video that they're using to be able to model what happens in the vessels around the heart, and they can actually tell whether the surgery is going to work. And clearly, the technology in some specialties in medicine is absolutely fantastic, saves a huge number of lives, it's really, really important. But it's not exciting. I can assure you. Because once you've done that avatar game 50 times, there's not much else to do. You get to level 1 and that's it. All right? Whereas psychiatry is always different. So let's address this question. So my interest was in treatments as well as diagnosis. This is John CADE. This is a picture that hangs in Royal Melbourne Hospital, I believe, and a copy of it was sent to me by his son, Jack CADE, who's an intensivist in Melbourne, and we wrote a little article about his father. John CADE's extremely important. He had a very wonderful life as a doctor, as a physician. He was born and brought up at a time when there were a number of wars around the world. He conducted himself admirably in that regard. But when he returned to Australia, he was very much engaged in looking after patients. As a psychiatrist, he found, refound, or rediscovered lithium and its impact on mood stability, and in particular in the context of bipolar disorder. And he published a seminal paper in 1949 in the Medical Journal of Australia, a humble paper just looking at 10 patients, and he came to that after having tested the molecule on himself. So what he did was he thought this probably has some properties which are helpful, and he tried it on guinea pigs, he then tried it on himself, and then he tried it on his patients. Now, that study of 10 patients has been hugely cited, as you can imagine. Probably in the region it's been estimated to 100 to 200 million people around the world have directly benefited from lithium. And I think that's an underestimate. I think it's a much larger number if you also, include families and so on. And so a very simple study, an empirical study, in essence, that he did on himself, built through knowledge and intuition, made a huge advance. And right now, we still do not have a better agent for the treatment of very specific mood instability and bipolar disorder. And that's phenomenal. If you think about it, how many billions of dollars have been invested in neuroscience research, and yet we haven't been able to raise the bar beyond what he did in a shed, literally, as a superintendent of a hospital. Now, I point that out also for another reason, in that he didn't have to fill out what I have to fill out, forms this thick for ethics. I'm currently just about to start another study looking at lithium, where we're looking at the acute anti-suicidal effect. Tim would know about this. We were wanting to administer lithium as a lithium patch, as it were, and administer it to people so that if they're acutely suicidal, we stop them from being suicidal by giving them a shot of lithium and see how they go over the 4 weeks. The idea being that it has some specific anti-suicidal properties. Now, just for that, we had to fill this huge study, pro forma for ethics, and it's taken us 12 months to get approval for an agent that is, first of all, the third element in the universe, right? It's not new. It's been around a long time, right? It's been used in millions of people already. I'm not using something new. And I'm actually using it for the same people who it's been used for. I'm just tweaking it slightly. But I do have to go through ethics, and that means I have to spend 12 months of my life plus other researchers filling these forms in. John had it a lot easier in some respects. I am so envious of him. I would be doing things in my garden, which, well, I wouldn't be able to talk about them, but anyway. They would be fun, all right? There'd be no ethics committee looking at it. Anyway, so we set up this CADE clinic. The CADE also stands as an acronym for Clinical Assessment and Diagnostic Evaluation of Complex Patients. And in fact, the two people I saw today were exactly that. One had come all the way from the ACT in Canberra, and the other down the road from another hospital for evaluation. People who are really treatment resistant in terms of having mood problems. And that's the acronym that we used. This is the team. Now, you might be saying, well, where's Tim on this? Tim is the cartoon on the right-hand side of the bottom. Because the day we had designated to take this picture, I can't recall what you were doing, Tim. You had disappeared for some reason. It was very unlike you. But anyway, we sketched you in afterwards. And so I have a very diverse, wonderful group of people. Not all of them are there, actually. A lot of people couldn't make it for that particular picture. Hence, we've sketched in a few people to make it look like more. But we're very happy in what we do. And what we basically are doing most of the time, apart from assessing patients, is doing research projects. Some of the ones I've spoken about, others in terms of imaging, neurocognition, therapeutic studies. We look at the genetic makeup, neuroendocrine and physiological makeup. And so we're doing a lot of assessments. So most of our patients, when they come, they'll stay several hours with us doing all of these. So these are, unfortunately, only single assessments because we can't see people repeatedly. We have to then send them back to Canberra or Newcastle, or wherever they've come from. And we do advise on longer-term management of some patients, particularly those now that we're starting on lithium. So, why do all of this? Well, you have to see patients. As a doctor, you will be the person who sees the problem. And what I mean by that is, when you're seeing your clients, I hate that word, when you're seeing people, you will be able to see what the problem is, how they are experiencing distress. That's what you're trying to resolve. And you have to remember that, because when you take it into the lab or remove it into a research arena, it becomes rather pure in the sense of a research question, but actually separated from the reality of what the person is experiencing. And that's a shame, because then we have to bridge it back into clinical experience. And I like the fact that I do see patients because it keeps me very close to the problem. It's very easy to disappear down some rabbit hole, do research that has no relevance to clinical practice. You think, aha, I found such and such. And then someone says, so how's that going to help people again? And you think, not really sure. And so it's important to be seeing patients. And so you identify the problems and then you look at them. And if you're doing research, which is I would definitely say you should do, then you're able to actually answer those questions. I put this up only the reason for this is that this is a very comprehensive overview, published only last year in the Lancet. It covers everything about depression. So if you're going to read any paper around depression, this 12-page document will give you the lowdown in terms of neurobiology, the treatments, the pathophysiology, pathogenesis, and so on. I'm just going to give you an overview very quickly of some of the facts. And it's quite depressing in terms of the actual facts themselves. 4% of the population experience depression every year. 15% depression in their lifetime, and in primary care, 1 in 10 patients. That also means that as a doctor, it doesn't really matter what kind of specialty you go into, you're going to see psychiatric patients and you're going to see psychiatric problems. So this is one module, one area that you really do want to be an expert on. And any investment in this area is good for you. It doesn't matter where you end up as a doctor, you're going to see so many patients with depression and varieties of depression, in particular anxiety disorders, bipolar disorder and eating disorders, obsessive compulsive disorders, and so on. You do need to be armed with knowledge. They often do present with depressive symptoms, but depression can also present in a myriad other ways. The average onset is rather young, but there are peaks throughout lifetime. So it doesn't go away. So even elderly people can be depressed for the first time. And very, very young people in puberty can be depressed for the first time. So it really does touch virtually everyone, and certainly everyone in terms of families. There is, oddly, a peak later on. People talk about depression a fair bit, and it's thought that maybe depression is a young person's disease. It's not. It covers the whole lifespan, and in fact is more common as it gets a little bit older. The other thing that's curious is that it's twice as common in women than men. And you'd think we'd know the answer for that and why that's the case. But we don't. And so there's a question immediately. Why is there such a strong, consistent gender bias worldwide that's independent of culture, independent of socioeconomic status, diet, you name it? There seems to be something about being a woman versus being a man that renders you twice as likely to get depression. And as a father of 2 daughters, living with my wife and mother-in-law, need I say more? I'm very interested in how women think. And we did a study, and I'll come to that in terms of looking at adolescent girls. The course and prognosis of the illness, often insidious, sometimes abrupt. Unfortunately, its manifestations are myriad, and it varies. And even in the same person, it can present very differently from one episode to the next. Now, this is important. Once someone gets depression, the likelihood of getting another episode is almost inevitable. And I would say you err on the side of assuming that they're going to get another episode and do whatever's necessary to prevent it. We often stand back and say, oh, well, maybe it's only one episode, they're not going to get a second. But by the time they get their second and third, then it's almost 100% chance that they will have a further episode. So the illness is chronic, it's recurrent, and it's lifelong. And therefore it's serious. And hence why the World Health Organization predicts that it's going to be the #1 cause of burden worldwide in 2030. That's not too far away. And that's mammoth. Just imagine that. That's more than infectious diseases. That's more than cardiac disease, more than diabetes, more than cancer. It's going to be the #1 cause of burden worldwide. That's something to think about, rather sobering. Average episodes are 3 to 6 months. Majority do recover within 12 months. Now that's intriguing. What do I mean by that? I might pause there for a second, just to add dramatic effect. I wasn't expecting anyone to jump in, and no one did, thankfully. What I'm really alluding to is we're often, as doctors, thinking that we're trying to treat someone, and somehow what we do, administer, alleviates their depression or their illness. If we go back to archival records and we look at people who were locked up in asylums, given all sorts of unsavory names at the time, and they had depression, severe depression, where they would stop eating, stop drinking, stop moving even, get catatonia, they actually recovered spontaneously, on average, between 18 months and 3 years later. And what I mean by spontaneously is without intervention. So there weren't any medications anyway. They were put in straitjackets or locked up. So what does that tell you? So this is not like a heart attack. What this is saying is the brain is able to reset itself, given time. So whatever this illness is, we don't know its full nature. It is something that the brain is able to overcome, given time. And there are restorative processes and procedures within the brain that allow that. Now that's fantastic. That means if we knew how to identify those, how to facilitate or augment those, that in itself is a therapy. And furthermore, if we were able to enhance them to the point where they could be preventative, that's to say they are protective against you developing depression, you actually have immunity towards depression. Yeah? And that's evident, that we know that that's a possibility because of this observation. So this is the way of thinking about the brain, thinking about what happens to the brain and conceptualizing models that may help in terms of devising new treatments. This is just a schematic showing what normally happens in terms of remission and recovery. So I mentioned finding answers to questions. This is the privilege of doing research. When I'm driving around and I leave the hospital at Royal North Shore Hospital, I work in the public sector. There's a lovely, shiny hospital across the road, the private hospital. I always go there for a coffee. That's the only thing I can afford. And then I go back to the public hospital to have my lunch. When I leave the hospital and go home, I'm usually at the traffic lights in my car with a Lamborghini and a Ferrari. The surgeons have pulled up. They've just left the private hospital, and then they leave me for dust. But, I'll go along happily, and at the next set of lights, I'm with them again. Much to their annoyance. At which point I will pull out an apple, eat all over myself, spit out the thing, throw stuff. The point I'm making is, why do you want to do academia? Why do you want to spend your nights and weekends asking questions? You've got to have curiosity. You've got to have enjoyment in that. One thing I do, I look at the two colleagues across, and they are miserable. And I give them my card. come see me sometime. You know where my car is, and you can catch up. Right? Where's that little recording? Psychiatry is what you need to do. Answering questions. That's what really turns you on, isn't it? It's the curiosity. Even in relationships, we've been joking about 14th of Feb and all of this stuff. But what is it that's most exciting in a relationship? Is actually to know whether someone is also attracted to you. That's the key, the essence, which Shakespeare captured so wonderfully. It's that initial excitement that sparks the relationship all the way through. And that's what we want to know about questions. We're trying to understand ourselves and the world all the time. And if you can bring that into your research, then you're never, ever going to be bored. You're always going to be excited, and you're hopefully going to find something that's going to be really meaningful. So this is the study I talked about. Tim was very heavily involved in this. I'm indebted to him in terms of the assiduousness he brought to the project. He was involved in the scanning and the ideas, and in terms of analyzing some of the data. And it's been a wonderful project that's run through the department for many, many years. And I initiated it because my daughters, who are now grown up, were at the time going through that vulnerable phase. They were going to a school. And it occurred to me, it's twice as likely in women than men. Girls are more likely. And when does it normally occur? In young adolescence. Why at this particular time? Is there some way of preventing the illness, identifying changes that precede the actual full-blown illness itself? And so we had access to what we called lovingly Archie, Advanced Research Clinical High Field Imaging Facility, which we managed and ran our scans in. It was a 3T Siemens scanner. And there's Dr. Althred. There you go. In all his glory with Dr. Das, who's the senior research neuroscientist who does functional analysis. And that's Archie. And we would have a nice operating room where we would present stimuli in the scanner. Functional MRI is what we mainly focused on. And these are the girls. So these are an example of 4 girls that came to one batch of studies. That's Danielle Gessler, who's now doing a PhD at University of Sydney in psychology. And she would manage them at the time. And we would have them for about 4 or 5 hours. They would do some neuroscience with us. We'd make it fun. Then they'd do the scanning, then some neurocognitive testing, some assessments. Then they'd have snacks and tea and sugar, and then they'd bounce around. And the whole team loved the study. It used to be great. But we ended up scanning several hundred girls. So this took a long time. This is why it took a long time. We did them in batches of different ages, and we also followed up some of those girls. And as with all kids, they love getting some sort of certificate. So we would give them a certificate of participation, and their eyes would light up. Like, woo! Yes, you participated in the study. Yes, that's right. That's what you did. But it worked. It was great. We would give them that, and we used all the cheap tricks in the bottom drawer, which was giving them chocolates, even though I had promised to the teachers that we wouldn't do that. And we would also give them a Hoyt Cine voucher, which makes everyone happy, doesn't it? But it was a great study. And this is some of the findings. I mean, there's lots of findings, and we're still analyzing some of the data, and some of those papers are still coming out. Hence why I keep Tim busy, as it were, on weekends and early evenings, sending him data to look at. And here's some preliminary data going back to 2013, published in Biological Psychiatry. And what we found was that there were changes in a key part of the brain called the hippocampus. Now, most of you will know about the hippocampus as being important for memory. Short-term, long-term, but actually processing memory. It's really fascinating that this is one of the parts of the brain, alongside the olfactory bulb, that creates new cells all your life. So if you want to get a new brain cell, you're not going to find it in other parts of the brain once you're an adult, but here you will, and bits of your olfactory bulb. And that was a recent discovery, only in the last 15, 16 years, that we've known that neurons keep getting created as stem cells in this part of the brain. Now, the hippocampus is also core to your emotions. So it's linked very strongly to the amygdala, the medial prefrontal cortex, the insula, and it integrates all that information. And it makes sense, doesn't it? Because if you really want to understand whether you like someone, you've got to first of all know who they are, you've got to recognize them, and there's also that context of past shared memories. So all of that comes in all at one time. When you recognize someone, say, oh, that's my friend over there, you're evoking all of those things, and the emotion comes with it. So the hippocampus is obviously integral to that. What we found when we looked at these girls, and these girls were healthy, all of them were healthy, was that the hippocampus in those girls that had more emotional symptoms that's to say a greater number of symptoms and symptoms of greater severity, probably most likely a prelude to developing depression later in life, versus those that had fewer symptoms, they already had changes in the brain that we could detect, in the hippocampus in particular. And what we found was significantly altered blood flow to this part of the brain and diminished activity to this part of the brain that is correlated with trait anxiety. And that's what you're seeing in front of you. You'll see the line going from your left to the right downwards. On the left, you have the hippocampal signal, and then you have trait anxiety along the x-axis. What's also interesting is the graph below shows the connection between the hippocampus and this wonderful network that it has. And the way I try to think of some of these bits of the brain, you have to create a story around them. And often people will say, oh, the insula does this and the insula does that. What does it actually do? These are suppositions to some extent on our part, but we also do know a lot about various bits of the brain. But if you think about it, you can't talk to your computer. Actually, I take that back. You can talk to your computer now because Google and everyone else has sorted all of that out. But if you try to talk to your computer, you have to communicate in such a way that it can understand what you're saying, translate that into digital signal. Now, the brain also works on signals, chemical signals, but still signals. So when we are experiencing anything in the world, it somehow has to be translated into that. Insula is one of those parts of the brain that does a lot of integration. It brings that information together and kind of presents it to other parts within the limbic system in a way that's digestible. It's also sifting out unnecessary information. So these parts of the brain are really important, and the hippocampus coordinates all of that information. And what this graph at the bottom is showing is that the girls who had more emotional symptoms in the red versus those that had fewer, which were closer to being healthier, so we'd say, in the blue, had coupling between those structures in opposite directions. So what you can see is the healthy girls with the blue have very strong coupling, strong linkages between those areas. So you can imagine the insula holding hands with the hippocampus, holding hands with the medial prefrontal cortex, and so on, and talking to each other, whereas the girls in the red, they've broken hands. They're not talking as much. They're uncoupled to some extent. So the network is not really working as a network. It's not cohesive. And the actual input and flow of blood to that area is diminished. Now, this is only one study, all right? So can't get too excited about it. But it's a signal. It's a sign. And so we've been building on that. And the fact that it correlates with clinical symptoms is what's given us heart to do other studies. So this is a schematic showing the same, where in the healthy girls on the left, you've got the hippocampus. It's a coupling with the insula, amygdala, inferior frontal gyrus. And on the right, changes in the girls who are prepotent in terms of developing mood disorders. Now, we can also do more sophisticated analysis. I'm not going to go into great depth here what these slides are showing, but this is just to show that there's other types of data that we've also collected. This is not necessarily task-related. That's to say they're not doing things in the scanner at the time. They may just be wandering in terms of their mind. The thoughts are just randomly being associated. But that also gives us information about how intrinsically parts of the brain are connected. And we can work out which networks are more active when the brain is resting. And that's actually quite important as well, because the natural state of the brain is probably where some aberrations are most evident, rather than when it's being stressed or asked to be excelled in a certain way. So this is ongoing. We've found all sorts of wonderful things related to emotion regulation, and most importantly, the self, which makes sense, because these are adolescent girls. The idea is, this is the time when we actually individuate. We develop a sense of self. It's also when we move from having many acquaintances to a smaller number of more meaningful relationships. We're also gaining a better understanding of the world. So a lot is happening. And if you think about it in that way, you have to sort of stand back and think, wow, how does the brain do that? I mean, that's really, really hard stuff. I mean, we sit in front of a Krebs cycle and think, oh my God, I've got to learn this now. Where do the enzymes go? And what the hell is happening to cyclic AMP? I hate cyclic AMP. Anyway. And we're trying to commit that to memory. But the brain does all of this automatically. This understanding of the world, positioning things, understanding others, and being able to transplant ourselves into the thinking of others. So there's endless amounts of work to be done here, and a fascinating series of studies that you could do, which would give us some further insights into how the brain functions, how the mind functions, and how we think. Some of those girls we followed up, and this is just a quick slide to show that we saw changes over a period of 2 years in terms of the clinical symptoms and how those then correlated back to the original changes in the brain. And this is, again, I could just talk about this slide for 45 minutes in terms of untangling all the findings. But in essence, this is again showing that during these key epochs in adolescence, in girls that are otherwise healthy, there are already significant changes that are signaling future anxiety symptoms, future depressive symptoms. And that's where our longitudinal study is now going. We're hoping to follow up these girls and see whether that's the case. We've also got another paper looking at different age groups and correlating changes. So I just wanted to give you a sample of when you're seeing people, and the people I saw today, for example, they're struggling with their day-to-day functioning and life. At the same time, you're having a question. What is causing this? Where did it start? And is there a way that I can answer another question that this person is going to ask, which is, I've fallen pregnant. Is my child going to get depression? And are you going to be able to prevent it? And these are tough questions. We don't know. We don't have the answers. But this is the type of research, and many, many other wonderful centers around the world just doing fantastic research collectively are likely to be able to answer. Another area that we're really looking at closely is suicide. Now, again, this is not a shock horror kind of word. Everyone knows suicide. It's almost part of our lexicon, and probably used too often, in fact. We've become rather blasé about it. But we looked at this as a process. We dissected it out. We've looked at its neurobiology, neurocognitive aspects, how it links to personality, and seen its evolution. And then we went to the American Foundation for Suicide Prevention, managed to get 2 successive grants from them, and we've looked at brain imaging changes in patients that are susceptible to suicide, looking at low and high suicidality, and seeing what are the network changes. In fact, we have 2 papers right as we speak, currently being assessed by 2 journals. I think I'll call up Tim every day saying, it's still not come back. And we found some very nice differences between those that have high suicidality and low suicidality. And the idea here is, if we can understand suicide as a process and also know the neural basis, then it provides us a target to actually monitor change and monitor whether we can actually have a therapeutic effect with psychological interventions, for say. At the moment, most things are non-specific. And you might have heard of some of the initiatives that are being put out to prevent suicide, which is, stop people from jumping from bridges, make it more impenetrable, put up fences, etc. I mean, that thinking will basically mean that all roads have to have fences, so that you can't step out in front of a car or a bus. It's illogical. What we really need to do is understand the mechanisms of the brain. What is it that leads someone to attempt or even contemplate suicide, let alone actually go through with it? It's quite a phenomenal event in and of itself. So again, I just want to really highlight that there is real research and hard research and complicated ideas that you can engage in alongside your doctoring. It doesn't matter what area of medicine you're in. And the other aspect of this is you want to be able to influence practice. You don't want to just do the research. You want to feed it back into your clinical work. So in my role, what I've done, and Tim, I think, mentioned some of this, is I've published heaps of books. Some of those books go back right to my training years when I first started out in medicine. And this is just a tip. If you're studying it and you're taking notes, make a book of it. It just doesn't make sense to me. All of you write so neatly, you use multicolored, you highlight stuff, you annotate it, looks beautiful. And then what happens? Once the exam's over, I don't see the point. Publish it. It will save the next person heaps, because you've got those notes from 17 books, footnotes, and conversations you heard, and stuff you pinched from other people. There is no other set of notes like that, right? So why would you not? And it's very easy to publish. The other thing it does is actually consolidates your thinking and your reasoning, and actually putting it in a format which it gets published makes sure you really understand it, because you don't actually just understand it yourself, you have to put it in a way that other people can understand it. And that's even harder. But it means you then really know the stuff. And I wrote this book, Neurology for Psychiatrists, really more so to annoy neurologists than psychiatrists, really. I just wanted, again, for them to remember that they may know a little bit about the brain. But we know about the brain and the mind. All right, this is where the little thing comes again, be a psychiatrist. hopefully this is going to haunt you. Sorry, you're going to enjoy it, not haunt you. That's wrong. Haunt you is haunt you. Okay. These are more recent books, Troubles and Disguises, Science and Practice. So it's something that you can have joy from for the rest of your life, writing books. All right? The other way you can influence people is writing guidelines. So there's published guidelines a couple of years ago, and they're quite useful in terms of setting standards. And I certainly think in psychiatry we've been catching up a little bit with other specialties. Other specialties have done this, I say somewhat begrudgingly, rather well in terms of identifying clear pathways for management. That's been harder in psychiatry, but I think we're getting there. We're finding ways of developing rigorous protocols for assessment, management, and so on. And so you can feed your research back meaningfully into clinical practice, and these are the journals that I mentioned earlier. Now, I'm keen also to have some questions and discussion, so I'm going to shut up in a few minutes. But I just wanted to mention one thing, which is stigma. And it's really important, because it's not unique to psychiatry. It's the essence of who we are. And if you think about what happens in the media at the moment and what news is about, everything is about difference. Everything is about change. Everything is about elevating one group and diminishing the properties of another. And we do this automatically. Part of our hard wiring in our brain, unfortunately, is such that we only get titillated or excited by change and difference. If you look at something very blank, your brain doesn't register it. I came across a very nice term. I'm not sure if anyone's heard of it yet. A Vanta black. Anyone know about what the Vanta black is? Yes? You want to shout it out? What it stands for?
I think I'm thinking the wrong thing. It's an acronym.
Oh, what did you think of?
It's like that new shade of black, don't
Yes, it is, yeah.
they? So it's like it can remove like the three-dimensionality of objects when you're looking
And why does it do that?
at the chemistry.
What's that, sorry?
Because of the chemistry.
Yeah, good guess. Yeah, okay. You could have gone 50-50, call a friend, but no. You just went in and you lost your money. All right, you're back in the queue. All right. Stands for vertically aligned nanotube. What was it, T, wasn't it? Nanotube something. Vertically aligned nanotube. No, nanotube array, right? Vanta, right? And look at that technology. What they found was that by having these really, really thin rods aligned in such a way, light bounces on the actual rod. It then can't escape. It bounces onto another rod, and it dissipates as energy and therefore gets absorbed, so nothing gets reflected. So 99.96% of the light gets absorbed. So hence, it's totally black. And it's so off-puttingly black that you can't actually see it, because there's nothing to see, literally nothing to see. See, we see black, we see lots of black, and we can still see shape. You can see shades. And even in the darkest room with black, you'll still be able to see some sort of shape. But this you can't. And therefore, it just looks like someone's put a cartoon hole in space. It's absolutely beautiful, right? Now, how did I get onto Vanta Black? I can't remember what was the point of that. I'm blaming you because had you got the question right, I would have stayed on track. I would have stayed on track. So I was talking about differences. And our brain is gauged at those differences. And when it goes to that extreme and can't make that discrimination, then we're totally lost. So our eyes, our senses are always looking for change in our environment. And that's what our brain is feeding on, so as to get a 3D perception of the world around us, right? It's ultimately an illusion. I have an image in my mind which I think correlates to yourselves, one wearing a blue jumper, the other one wearing a red one, etc., etc. But this is still a construct in my mind. I haven't come over there and tested that. I mean, I could, but it'd be really weird, wouldn't it, if I started feeling it over? And you sort of said, are you blind? No, so I'm just testing my hypothesis. I thought it was blue and red, and there you go, right? But so we have this. But it's quite phenomenal that we're able to do that. But it, unfortunately, rests on this property of discrimination. I haven't used that word until now, but that's what it is. When we say discriminate, we see to be able to find a difference. And it's relevant to my work in terms of stigma, because we're trying to all the time educate people in the hope that by knowing, somehow that will diminish stigma. But what's surprising, to me at least, is that we're not making as far an advance or as fast an advance as I would have imagined, given how much we know. And we can talk about race, we can talk about gender, we can talk about all sorts of things. But in the realm of psychiatry, mental illness, though even in Australia, the awareness is massive. A lot of people know about mental health problems compared to 2.5 decades ago, when the awareness was very low. And yet, day to day, the stigma that people with mental illness experience is pretty much the same. So there's something amiss with that high-level, advertising of the subject versus what actually happens in a behavioral level at individual interactions. And that's a gap that we haven't solved. So stigma is really important and critical, but it also opens the door to other aspects that I think are really important. I mentioned them in passing, but I think philosophy, understanding how we think, how we engage, how we garner knowledge, understand the world, and also have an understanding of what we really know, the epistemology of the world around us. That's really key. At the same time, the ethics of what we do. As doctors, you really need to know ethics. This is your area that you should be masters of, because every action you have has consequences, which has moral consequences. And if you're not aware of that, you could fall foul of it very quickly. So science is really, really important to being a good doctor, but there are many, many other aspects which will allow you to broaden that horizon and be a much richer and better doctor. And once again, I'm just going to... All right? So be a psychiatrist, is what I'm really saying. This whole lecture is about that, actually. Unashamed advertising. All right, I'm going to stop there and allow you to ask me questions.
Okay, so who's first? Not all at once. You have your hand up. No. Any questions for... Yes. There's a roaming mic.
Does it work? Yeah.
Yeah.
I think what you were saying about the stigma, I feel that there's a large stigma around mental health because of the reason that I guess there's no, correct me if I'm wrong, but no particular gold standard. So, for example, if someone has a ligamentous injury or a fracture, there's an MRI or an X-ray to pretty much prove that it's a pathological and a real condition. Is there any way that patients can undergo some sort of investigation that would, I guess, provide that evidence that they are mentally unwell and therefore receive treatment?
So that's a wonderful question, and what it's layered in is this aspiration towards having the ideal medical model. And the medical model is a very simple one, that there's a pathology or a disease process. It leads to some sort of clinical syndrome. We can detect that reliably. We have a biological test, and we can verify what we're seeing. And there's a lot of medicine now, and I alluded to some of it, where you can do that. But we have actually been duped a little bit, because I challenge you that if you went to that same doctor and didn't go with a fracture or bleeding, but said, actually, I think I've got a sprain, all right? And it's actually quite a debilitating sprain. I can't weight bear. I can't walk. They will do a very high-resolution MRI scan. It may or may not show something. They might do ligand-binding studies. They might do all sorts of other scans. They still may not see anything. They'll palpate. They'll feel. And then it comes down to conjecture. And the doctor will ultimately say, my best guess is, my informed guess is, this is what's happened. So the judgment factor still comes in. And what actually determines whether you go or not is actually dependent on you. You could be a very stoical athlete who says, nah, that's okay. I'm going to rest up for the weekend. I'll be fine. Monday I'll be able to walk on it again, no problem. You could, on the other hand, be someone who's very, very conscious of any kind of pain and show up immediately and say, I can't, this is intolerable. So there's huge variance. The actual pathology hasn't changed. It's the same problem in the two individuals, but they've dealt with it very differently. And if you went to a separate doctor, how they actually deal with that would be very different as well. So psychiatry is not that different. So, even though I've spoken about the challenges in psychiatry, many of these apply to medicine as a whole. There's only a few pockets within medicine where you can say, yes, there's a bug, we killed it, we know, we tested it. A lot of it is guesswork. A lot of it is still an approximation. And even simple things that we take for granted, like blood pressure, really, who's to say what's the normal blood pressure? And who's to say how it should be treated? And if you see dietary advice and exercise advice, etc., it changes from season to season, more so than the fashions. So I wouldn't buy into that. But certainly in psychiatry, what we are trying to do is identify concrete, specific pathology within the brain that underpins the key disorders such as depression, such as bipolar disorder, schizophrenia, OCD. And I think from there we'll have some nuggets to build on in terms of extrapolating to other disorders.
Hi. So I was just wondering, how does the presentation of mood disorders present across cultures? Is depression the same if you're in Australia versus India versus Colombia? I just want to see if, mainly because the study of psychiatry also encompasses mental processes and behaviours, whether that would influence how it presents.
Yep, look, and that's a really good question. I can send via Tim to you a book chapter we wrote only last year, which says the pigment of depression is more than skin deep. And I wrote that with Yushila Bairo. It was looking at the cultural differences of both the prevalence and perception of depression. And we compared a number of data points, studies that have been done around the world. And the main difference seems to be the cultural elaboration of the illness. So going back to the other example we had, let's say depression is a wholly brain disorder, and there's something wrong in the brain, as our hypothesis to start with. The expression of that is going to be very much, first of all, dependent on the brain itself. That's to say, what does it do about this problem? How does it perceive it? And that immediately brings in all it's learnt to that particular point to deal with other problems. And that's where the culture comes in. That's where your past experience comes in. And so that's why the problem is manifest very differently. So depression, yes, looks very different in different cultures. And therefore, grading and comparing and assessing across cultures is almost impossible. But within cultures, very consistent. And often what we're looking actually for in terms of treatment is change within the individual. And there it's very consistent. So even if my expression of depression was very high and very flamboyant and very colourful, you're looking for a change in me over that time versus yourself maybe. You might be more subdued and sedate about it. But then again, we're looking for change in your particular assessments. So when we look longitudinally in individuals, we note that the pathology is virtually identical. Its expression is hugely different. And that also lends itself to biases, because some of the behaviors in some cultures obviously are frowned upon. And so that's where, again, the stigma against mental illness. And I'll just add one thing there, that still in many cultures, mental illness is seen as the work of the devil. I mean, there are parts of the world where people will not mention they've got a mental illness, even if it's extremely severe, because of how it's perceived by their own immediate community. They'll be ostracized, and the person will be stigmatized for the rest of their life. So those are the challenges which I find really tough. You know, that we can do the science, we can do other things, but this gap and understanding why this is the case is proving to be a much more insurmountable problem.
Thank you for the talk today. I guess it's really clear that you've been very proliferative throughout your career, writing and publishing, and I was wondering...
I'm glad you qualified that. I was wondering what you were alluding to. I was like, do I know this person? No.
So I didn't realize that had double meaning there. So I was wondering who might be the key writers, be they from philosophy or psychiatry or other disciplines, that might have influenced you, that you might follow and read. Like, who do you follow in terms of reading? Yeah.
Look, I've been very fortunate. I think it's really important in medicine to find good mentors, all right? And don't be bashful about going up to people who may initially look intimidating and saying, I need your help, or I'd like to ask you a question. Because what you don't realize is they're exactly like you. They're just a lot older. They really are. And so if you have the confidence in the coffee, you know, when you're going for a coffee at a cafe to approach someone, just imagine that person 30 years on, and that's all you're doing. They will be delighted, almost always, to chat with you, to understand what your questions are, your curiosity is, and that's how mentorship starts. And I've been lucky. I've worked in good places. I've come across good people, and they've always been supportive, and I've kept links with them. As an example, I'll give you two people straight away. I'm in my 50s now, and whereas I speak regularly to a colleague of mine from whom I actually inherited the Bipolar Disorders Journal, Sam Gershon. He's 93. He's in Florida in Miami, and I speak to him, and I only spoke to him just around Christmas time while he was on a cruise in the Caribbean. And he was like, Gin, how are you? Man, these waves, oh my God. But the food is great. And I'm like, Sam, you're 93, slow down. Okay? And Herman Berrios, who I came across in Cambridge, he's in his 80s. He's a Peruvian polymath, someone who's done maths, physics, and 7 languages fluently. And I was very fortunate to have him as a mentor, and he's always been available. You drop him a note at any particular time, and he's my sort of equivalent of the Bodleian Library. I'll sort of say, Herman, I heard there was some discussion in the French psychiatry in the 19th century around this particular concept, and within a day or two, he'll come up with the citations and say, yes, I looked at my own library. He's got a huge library. And I found out, and I've translated it for you, blah, blah, blah. And so you just have to cultivate that tier of people who genuinely are interested in you and will assist you in your particular sort of quest. In terms of reading, I honestly would say to you, medicine is fantastic to read and it's great, obviously there's lots of stuff there, but it is, at the end of it, somewhat dry. So do read philosophy, do read other things, ethics, law, all very important. And that way you really are able to integrate models and ideas and bring them with impact on your own practice as well.
Hey, thank you again for the talk. I just wanted to ask, you referenced earlier about the possibility of experiences being passed on genetically. Do you feel like people, and maybe more specifically children's ability to identify with archetypes is a proof of this to any extent?
Look, that's a really interesting question. I mean, it harks back to Jungian thinking about this encoding of certain types of experiences in the brain. And I'll give you a slightly tangential example of a colleague of mine, Paul Groff, who's done a study in Canada looking at the longitudinal effect of lithium on mood disorders in 3 generations, and has found that specificity of response to this particular treatment has been transmitted from one generation to the next. That's a much more clearer example that, yes, there must be something transmissible. And if you think about it from an inoculation model, it doesn't really do me any good if I experience something and survive it, and I'm not able to capture that and pass it on to my progeny, right? So there must be a mechanism for me to do that. Otherwise, it means every generation has to experience all the same things again, and they always fall over. And though the Darwinian hypothesis is well and truly proven, what it didn't actually capture was this adaptability of the genetic makeup. And we were trapped in that thinking right up till the Genome Project around 1999, where we were thinking genes basically transcribed to proteins and that was it. What we now know is that the genes listen, that the genes in your body are constantly adaptive to your environment, encoding, incorporating that information and transmuting as you live, and therefore are able to pass on a much richer message. And that's really more meaningful. So yes, that's what we really want to be able to understand, but it also means the story is a lot more complicated than we thought, and we're going to need many millions of scientists to assist us in doing that. It's not going to be an easy task. These are great questions, by the way. Have you written them down, Tim?
No,
Okay.
they're not paid actors.
I think so. These are challenging.
Thank you for your talk. You've talked a bit about the treatment of depression and bipolar with drugs, and I was wondering about the efficacy of drug treatments versus things like cognitive behavioural therapy.
Okay, look, that's a great question as well. And look, it's timely because at the moment there's a huge expansion both in psychological treatments and physical treatments. And I'm a bit austere in the sense that I really think we need to lift our game. What's happened is, since I spoke about John Cade and lithium, in that same decade, in the 1950s, in the early 1950s, chlorpromazine was discovered. And from chlorpromazine, you had a derivative, which was the first antidepressant, imipramine. And since then, just imagine that, in the space of about 7 or 8 years, you get 3 molecules, an antidepressant, a mood stabilizer, and an antipsychotic, which cover the whole spectrum of psychiatric disorders. And since then, 70 years, we haven't been able to shift the efficacy. All that the focus has been on is better tolerability. That's to say they're safer, fewer side effects, easily accessible, and so on. But actually improving the game, that's to say they're better in terms of sheer grunt, hasn't happened. So that's appalling. Absolutely appalling. And they're not that effective. It's not as if they're already operating at 90%, therefore there's very little margin. They're actually operating at 30-40%. So there's a huge margin for improvement. We've just not done that. Hence why psychological treatments have come in. Physical treatments, there's been a resurgence of interest in that. But I'm somewhat skeptical because psychological treatments are great for modest and mild illnesses where the person is able to engage. So for me to be able to talk to you and you understand what I'm saying and also actually do some work with your brain to activate those self-rectifying mechanisms I was talking about in depression, for example. I said there was perhaps some spontaneous mechanisms that you can activate. In order to do that, you really need to be able to understand and cognize at a reasonable level. But if the illness is so severe, you're shut down, it doesn't matter. It's like, you know, just washing over you. You don't really absorb. And so we need that nuanced prescription of psychological treatments very early on and in the milder forms of the illness, but perhaps not so in the severe. The physical treatments, I think, are totally at sea. I think we don't have enough specificity in terms of understanding about the neuroanatomy of the brain, and certainly not its function, to be able to target specific areas with what are really blunt instruments at the moment. ECT only works because it affects everything. Right? It's basically, it's like steroids. When you give someone steroids, you're treating the whole body to a dose of steroids and you're resetting everything from a neuroinflammatory perspective. ECT does the equivalent to the brain. It just resets everything, everything discharges, you have a seizure, you have a general anesthetic, and that's it. But the other types of treatments that are coming on the horizon, TMS, for example, TDS and DBS, you know, these sort of sexy names, and the sale is, hey, it's going to be very, very targeted and we can pinpoint this. Yes, I think you can pinpoint nothing. And that's what's being done, and I'm very convinced you're missing the point. So I think we have a long way to go with certain treatments. Psychological treatments, alongside pharmacological treatments, need to lift their game.
Thank you.
Very, very sort of similar question, but just within your own practice, how important would you see counselling and sort of the softer side of psychotherapies?
Look, I think there's a lot to be said for being in the same space as a person. And that's another phenomenon which we don't really understand. It's been very exciting research looking at the brain responds differently if it thinks someone else is there. So they've done research, whether or not someone is there, if you think someone is there, your brain's already changed. That's phenomenal, isn't it? The fact that we actually are so attached to other people. So counseling, this engagement, the non-specific effects are really important. And we have lots of good research for that. So, for example, you look at any treatment trial, placebo does remarkably well. Now, no one told me to invest in placebo. I mean, that is the drug. The past, the future, it's going to be always there, and it does bloody well. It's cheap. I mean, wow, right? No one's buying the stuff. But why is that the case? Why is that the case? That is because that's the inherent mechanisms within the brain that we're just not amplifying, right? So there is something there, and that's where I think the psychological treatments and the non-specific therapies actually do have a role. That's what they're going into. They're having that non-specific effect, but it's profound. There is also something about telling your story and having narrative engagement with someone. We've all had that experience. If you're stressed or whatever, just by talking to someone, engaging them, and telling them, and you know they're not doing anything about it, and often incapable of doing anything about it, you still feel better. And so there's that aspect at all. I strongly advocate that, and I engage carers, family, etc., and try to do as much of that. I think one of the biggest problems, however, of modern society is, despite the scourge, and I use that word appropriately, of social media, scourge of social media, we are actually lonelier than we've ever been. And that's another conundrum for us to solve. Why is it that despite the superficial connectedness that we have, at a core level, we feel more alone and detached than ever before? And that's quite sad. And I'm convinced that at some level that is also feeding into this increase in depressive disorders.
I have one final question for you, Professor. Would you like
to... No,
to...
you can't get a pay raise.
Just... All right, I'll go.
I've told you 10 times.
Would you like to share with our fine audience, who's been very patient, about a patient that has maybe been a success for you in your career?
So there was one person called Tim. He came to me as a broken man. I said, Tim, that's a broken heart you have. You need a girl. So he got on that pony and went down to Melbourne and he found that girl. He put a ring on her and he said, yo, come up to Sydney with me and marry me. So that was a success patient for me, because I take credit for that because it was my idea. I don't think it would be appropriate to boast about the patients you treat. I mean, I'm gratified by the fact that patients do get better. A lot of them come back to me and say so, and it's hugely humbling when people do that, when people come back and say their life has been changed, and even having one or two people do that is enormous. It's a tremendous privilege. And as doctors, you'll be surprised, and I'm still surprised to this day, that people will psychologically undress before me and tell me things that they've not told their nearest and dearest. And that's something never to be abused.